I'd like to thank everybody. I'd like to thank Dr. Geller and the Zaccagnini Institute for inviting me. I'm not an optician. My role here is to make a few general reflections to put presbyopia in a context in relation to the individual's quality of life. Frequent visual defects sometimes have a cumulative effect and tend to influence one's own image, the feeling of confidence vis-a-vis social relations and one's own identity. And this may be amplified by other physical changes, such as changes in the hair, wrinkles, body weight, sexual performance, diseases, losses, and feeling of failure, personal failure. Well, this is from the International Society of Geriatrics. This is written in English, but I'll explain in Italian. It shows that your personal experience, the way you experience your age, affects the way you perceive aging. So aging as a subjective experience. In your lifespan, you go through certain phases. From a certain age on, the way you perceive your age affects very much how you live. This is a study where questionnaires were administered on the perception of physical health, the feeling of tiredness during the day, and the extent to which one feels that the others contribute to one's own well-being in life. You see that the way these diagrams are broken down is different. Physical health is perceived very well by people who feel younger than those who feel older. The conditions of all the respondents were the same. Also, the perception of tiredness changes. Well, feeling tired would seem to be a subjective criterion, and also the contribution of others to one's own life changes a lot. This is a starting point to try and understand how people experience certain things, including the communications or the information you provide them with. I have selected some concepts for interpreting presbyopia as a sign of aging. The first one is the lifespan perspective, trying to put the health and disease processes of an individual in a context. The second approach, the second concept is the levels of biopsychosocial organization. And the third point is the representation of health and disease that we all have. This representation changes considerably during one's own lifespan. From a social standpoint, we have to consider norms, social norms, how culture changes the expectations that one has, the activities, and the level of participation in relations. Everything that happens to us in our lives concerning health and disease is to be put in a broader context of life. This is a summary of all the concepts which are encompassed in the lifespan perspective. I won't dwell on each one of them. I will mainly focus on behavior, relational aspects, and psychological aspects. Many patients come to me for many reasons. They often have difficulties accepting that time passes and that people have limitations in their lives. Social network, the partners, the society. Well, this is the context where you interpret what actually happens to you in your personal life. We're part of a herd, so to say. We cannot conceive ourselves as standalone individuals. We live in a context. The quality of life and lifestyle concepts will be covered in my last slide. And then coping is another point I'd like to touch upon. Coping means all these strategies we can implement to deal with changes. The type of strategy that we apply will make a considerable difference on the outcome. Concerning psychological aspects, we should mention attachment. We know that the attachment dynamics have to do with our sense of security or insecurity. Whether we feel more secure or less secure has an impact on how we deal with challenges. Then how we deal with things, we all have preconcepts. We all have different mindsets, and information is filtered through in different ways. Then we have different ways of dealing with conflicts. We have unconscious defense mechanisms. I focus on all this whenever I have patients experiencing difficulties in accepting the limitations which from a certain time on may emerge in their lives. Then we have the biopsychosocial perspective as proposed by Engel and Schwartz. Biological, psychological, and social factors are intertwined. Biological factors, organic structural aspects, functional aspects, as previous speakers already mentioned. Functional aspects meaning an impact on performance and outcomes. Then gender and age, being a man or a woman in our culture implies that you have different perceptions of your own limits, and also genetic makeup. Then you have the psychological part, which is emotions and concerns. In other words, the way in which all these events and all the information that we receive starting from middle age dealt with. And patients need compliance for wearing spectacles or using some aids. your expectations, your conceptualization of all this plays an important role. Then the social sphere. There are jobs where physical limitations are more or less impacting your hobbies, your friends, your family, culture, economic aspects. The first paper today started from the social and economic aspects. I will briefly touch upon the biological aspects because this is not my topic. I've taken inspiration from a text by Moderato Rovetto concerning aging from the physiological standpoint. On the one hand, biological aging coincides with the end of the growing phase. Biologically, we cannot standardize when the growing phase ends. We don't know exactly the moment of starting from which aging starts. It's a variable concept. The other thing that impressed me is that aging is not just a reduction, a weakening of functions, but also a way of maintaining certain functions, processes triggered which help people preserve functions that we have used more in our lives. This is true especially neurologically. So the consequences of this process vary from one individual to the other. From a psychoneurologic and physiologic standpoint, there are no standard criteria. Aging is not a disease. You can't test it. Then you have the psychological side of aging. I have taken information from patient-centered medicine, an approach which centers on the individual rather than the disease. It's an approach suggested by Moya and Vegni in 2000. They identified 4 areas which should be considered by people who are even non-psychologists. So feelings, the interpretation of a disease, the cognitive side, how the patient puts the disease in a context, expectations and wishes, and the setting, the context. In my clinical practice, I found many of these areas as very important. First of all, chronologic age. If I asked you, am I old or not? Clearly, if you're 60, you would say no. If you're 15, you would say yes. But if you ask me, do you feel old? Then my answer is different. Be sure that sometimes I really feel old. There's a subjective sense of fatigue and tiredness based on one's own lifestyle and history. If you've gone through many difficult circumstances, many challenges, you may feel more tired than others. Then your lifestyle. If you're hyperactive, if you work a lot, your sense of tiredness increases over the years. Then social confrontation. We're part of a herd, so to say, and we necessarily make comparisons. We may know people that are our age but have gone through different life experiences. And then also, processes of health and disease that you've come across in your family. You may have a different approach to health and disease. Presbyopia is a sort of symbol. Presbyopia symbolizes a limitation. It symbolizes things that we can't do the way we used to do before. So the symptom is perceived as a limit. In my experience, perceiving that there is a limit, there's also a perception of deterioration, decay. The image of the self gets worse. Then you lose empowerment. This is, empowerment is the opposite of impotence. It means being able to do certain things, having control over certain things. This also means autonomy and independence. So loss of empowerment, loss of efficiency, and independence. Luckily enough, and you're here to bear witness to this, there are many ways of coping with limitations. Thanks to products generated by research, we can overcome certain limitations, but they are aids. You're no longer autonomous and independent, feeling reluctant to use spectacles. This is what we heard about before. This reluctancy is found also in many other spheres. Of course, we have to be grateful that we have all these aids and prostheses, but using them continuously reminds us that we're no longer independent in certain functions. Socially speaking, we live in a limitless culture, increasingly so. The idea is that limits are something wrong, not acceptable. You have to overcome limits. I searched on the internet. If you Google aphorisms and limits, the first ones are about limits for weak people. Michael Jordan says limits are just in our head. It's not real, because we can indeed overcome some limits, but not all of them. So limits are increasingly perceived as a loss of value. And this is why it is so difficult to accept that you have limits. Well, this is true even before being middle-aged. We know that we have limits, and sooner or later we have to come to terms with them. So the limited actual conditions clash all the time against unlimited ideal conditions. This is my final slide. It's a very long list. In Hughes' definition of the quality of life that other speakers mentioned, many components are involved. As professionals dealing with the care of people, in order to understand patients' compliance or patients' difficulties in complying, you have to understand all these factors: psychological well-being, personal satisfaction, social relations, daily activities, employment, physical and material well-being, self-determination, the possibility of choosing, autonomy. I think all these factors are very important, because if you have a loss of independence and less possibility to choose, this plays a very important role. Then personal competence, possibility of living independently, integration in a community, social acceptance, social status and adaptation, personal development, and the quality of the environment where you live, how you spend your leisure time. I work a lot with this. We have to come to terms with our limits, but there are many activities that we can start doing and that we have not thought about before. It's a new beginning. It's a way of changing. Sometimes, it is said that things have to change to remain the same. Our psychological image changes, but it should not deteriorate. We simply change our coping strategies, and what we do is change our leisure time habits to live our age in the best possible way. Our age is always the best one that can possibly be. Then social aspects, individual aspects, responsibility and support received from services. Of course, you have a major role to play. The first speaker today mentioned in his conclusions how important good communication is. It's largely been shown that physician-patient communication affects the compliance of patients very much. So please consider all these items, and please remember that your role is very important. Listening to patients, proposing them certain things in a certain way will be very important on the way they perceive their limits or the use of certain aids. Thank you.